I'm so thrilled to have Dr. Sallie Permar here today on The Interview. Dr. Permar is the chair of the Department of Pediatrics at Weill Cornell Medicine and Pediatrician-in-Chief at NewYork-Presbyterian Weill Cornell Medical Center and NewYork-Presbyterian's Komansky Children's Hospital. NewYork-Presbyterian is the #1 hospital in New York State, and it's #4 in the nation. So it's truly an honor to have such an expert in pediatric medicine with us. She received a doctorate from microbiology immunology from Johns Hopkins University, Bloomberg School of Public Health, and a medical degree from Harvard Medical School. She completed her clinical training in pediatric infectious diseases at Boston Children's Hospital, and after serving as an instructor and then assistant professor of pediatrics at Harvard Medical School, she joined the faculty of Duke University School of Medicine. In today's episode, Dr. Permar and I talk about hot topics in pediatric medicine, and not the ones necessarily making headlines, but issues that are on the minds of America's top pediatricians, and issues that should be on the minds of parents too. And with that, here's Dr. Permar. Dr. Permar, I am so excited to have you here today. We are going to be talking about hot topics in pediatric medicine, topics that you don't necessarily read about, right, in the news or not as commonly anyway. And it's just a real privilege to have someone with your background and expertise here to talk to us. So thank you so much for coming.
Well, this is a highlight of my week. Thank you, Leslie, for having me.
I love hearing that. I don't believe that, but I love hearing that. So there are so many topics that are in the news around pediatrics. Could be vaccinations or vaccination requirements. Those are that's an oldie but goodie, I guess. The effects of the COVID vaccine on adolescents, particularly adolescent boys. But I'm wondering, or what I wanted to talk to you about today are kind of issues facing pediatric medicine that are not as well known or not as frequently discussed.
Great.
So give us the inside scoop. What are you talking about? What are your colleagues talking about? What's on your mind?
Yeah, well, thank you for asking me that, because not everybody does, right? Asks, what are we not focused on that we should be focused on? And one thing that is really weighing on me these days as a pediatric leader, as someone who leads a department of 200 faculty, physicians who serve children, and as a national leader for pediatrics overall, with other department chairs of major academic centers across the country. The thing that really is dominating our thought these days is that we see that fewer and fewer graduates of medical programs are choosing pediatrics. And it's been a sort of steady trend over the last decade or so that fewer of the graduates of MD programs, as sort of the leading group that has filled those positions, but also other programs like Doctor of Osteopathy that often also fill primary pediatric roles, and those who are coming from international medical schools, all combined are continuing to have fewer of those graduates choosing to help children with their health needs. And it signals to us that we could be losing a generation of pediatric providers who are being trained in the most up-to-date knowledge of the best care and cures and treatment for children. And it makes us worry about what's the access for healthcare for children. It's already challenged in some parts of the country. We all know it's hard to find a primary care doctor that stays with your family for the long term. But also those subspecialists in pediatrics, those that go on and do additional training in areas like endocrinology, areas like genetic medicine or rheumatology. Those types of pediatricians are also becoming harder and harder to find. And that means that those children that do have identified diseases won't have those specialists. And so that is really what we're now all bonding together to figure out how we can turn this around.
So what do you attribute that decline to?
It really comes down to economics. And while I think we know children are cute, children are compelling, we all would love to make children not be sick, that we can't rely on that alone to draw people into the field. An underlying piece that really we see as the root of this is the compensation.
Okay.
So our doctors are, those that have gone on to colleges and then medical school, you come out with a lot of educational debt, and that has only been growing over the last few decades. But what is really not well known is that as a pediatric trained doctor versus an adult medicine trained doctor, your salary will actually be on average 25% less. And there's just not a capacity for graduates of many years of education that they've had to find the funding for or take out the loans for to accept that 25% gap in pay is not made up by just how cute children are anymore. And that we really have to look at the economics of this and fix what is leading to the lower compensation.
But when you say that they're compensated less, why is that? Is that an insurance company policy? And as you're explaining it to me, my first thought was, well, children being the mother of 3, particularly the first year of their life, and, I'd say 0 to 5, you're in the doctor's office all the time. And actually the first year you have set appointments. So is it because it's more costly for health insurance companies because the frequency of visits that they are not, is it they're not reimbursing at the same rate? Because I would think you'd have more activity as a pediatric doctor, I guess is what I'm getting at, versus a general practitioner. I go to my GP once a year for a physical, and I'll go in occasionally, for a prescription if I think I have sinus infection or something. But talk to me about that, because I would think that it would be a field where doctors could make even more, again, because they have just more visits.
Yes, so that would be great if that were true,
right.
But it is not. So essentially what it comes down to is how we fund healthcare in this country. I see it as backwards. So we are funding adult care at a level that is different than that of pediatric care. So over half of children in the U.S. have medical insurance through Medicaid. Those are children who live in low-income families, and that is the children's health care. And those that can afford to have commercial insurance or have families that have jobs that provide that insurance will have commercial insurance. But Medicaid, on average, reimburses considerably lower than that of the federal health care that is set up for retirees, for those that are 65 and older. That's Medicare. And so there's a discrepancy in even the same visit that you would have at a pediatric office versus an adult medicine office is reimbursed at a lower amount of money. And on top of that, we also have that the Center for Medicare, which is a federal agency, is the agency that has set the value of every activity that a physician takes on, whether that's an office visit or whether that's a surgery. And pediatric services and those types of preventative services that you are, doing your well child checks in order to get the preventative care that's going to prevent you from having to come back for sick care is valued at a lower level than that of a surgery that maybe takes the same amount of time, or an adult medicine procedure that takes a similar amount of time. So what that means is our pediatricians, while they're seeing children more often, doing a lot of the coaching parents on how to best provide nutrition for their child at whatever age, what to do for your child and their developmental stage, how to make sure that your child is not ending up with lots of teeth problems. Those are all things that are preventative care, take a lot of time to discuss with families, but are not really well reimbursed by that physician's time. So a pediatric doctor makes considerably less than that of an adult doctor on the reimbursement side. And that leads to the lower compensation that now our graduates of medical programs are responding to.
But do you think that the government is setting those reimbursement rates at a lower number because it doesn't want to have to pay out more because of the frequency of the visits? I'm just trying to understand, because it's not like there's a difference in expertise, for example, in a wellness visit of either. And as you pointed out, your pediatrician is sort of your frontline investigator, supporter. They're providing not just medical care, but a lot of information to new parents on child development, hitting those milestones. They also are mandatory reporters, so if there's an issue with a child. So what are the numbers really like in terms of decline? How big of an issue is it?
Yeah. So, one other issue that you're raising is sort of how did it get to this?
Yeah.
And really, it's a difference of where these national healthcare programs are administered. So Medicaid is administered at the state level. Medicare is administered at the federal level. And, despite all our differences in politics, I think Medicare is pretty set in its ability to persist and stay robust.
Right?
And those are the voters.
The 1-year-old does not vote.
that is actually, you got to the root of it.
But also,
a 1-year-old does not vote.
I don't think, that's why I'm so thrilled that we're talking about this today, because I don't think a lot of people know this. And I think if a lot of current parents of children under 18 or those that are planning families in the future, the idea of not having access to pediatricians. I mean, on a personal note, I have 3 kids, and one of my children had a real health issue and was treated at New-York-Presbyterian and has had to see a urologist and a nephrologist there for many, many years with a kidney concern. And we moved out of the city to Millbrook, New York, and we go to a pediatrician up there. And the hospital that's closest to us is Sharon Hospital. They do not have any kind of forget about pediatric department. They can't even admit a pediatric patient. So if you have an issue with your child, you have to be put in an ambulance and taken to White Plains.
Yeah.
And the same thing goes, there's another hospital called Vassar in Poughkeepsie, which is near us. If you have another pediatric issue, need pediatric surgery, you have to be transferred. Thankfully, we haven't had a medical emergency. I want to knock on wood, but we're in a podcast studio. I'm worried. I know that we're going to pick up the sound, Jess, right? If I hit I guess maybe I'll do it anyway, because that's sort of the point of doing it. Now I scared myself. But, and we're in a rural area, but not sort of too far afield of New York City. Talk about access in all areas of the country. It's a real issue and a real concern of not being able to have children be seen by people that understand pediatric medicine and pediatric needs.
That trained in it. Yeah, and I think what you're describing is exactly the result of how we fund healthcare in this country. And again, we fund it backwards. We spend more on health dollars at the older ages and, end of life, acute needs that happen, as opposed to the preventative care and investing in early life. And what we're seeing is these more and more hospitals are getting rid of their pediatric care because it doesn't bring in as much money as their adult care. And they can't, not only can they not afford to hire the specialists, because often those specialists cannot make even their own salary, but also they can't even find those specialists anymore because those specialists are so rare now.
Right.
That in order to attract someone to one of those locations, it's just a huge undertaking. And so this is what we're starting to see, more consolidation of those pediatric services. And it does mean that parents need to know. Parents need to know that it's not every hospital that you can walk into the emergency room and assume that there are pediatric trained doctors there. It's actually very few. And so one thing you should
matters.
know.
Yeah, that matters.
Yes.
Because having had one child in particular of mine who had some medical issues, particularly, she had surgery at 1 and that sort of thing, having people who know how to put an IV into a child of that age, or any kind of a scan and how you distract them, how you anesthesiology, all of those things are really need to be quite specialized for children.
Yeah.
So you mentioned that the states are in charge of Medicaid.
Yep.
Are all states created equal? I mean, are there certain states that are better than others? And are you seeing pediatricians going to residency programs or looking to build their careers in those states because of that? Or is there a correlation?
That's an interesting point you bring up. So yeah, not every state is the same. I think we all know that.
Yeah.
And that's why we choose to live where we do sometimes. But so every state is different in how they have set up their Medicaid payments. Medicare, again, very consistent across the states because it's a federal program. But Medicaid, it is up to the state budget. In fact, right now, our government in New York State is negotiating the Medicaid budget. And our hospitals are there saying, we need more of the Medicaid funding in order to make our hospitals work and to be able to serve children. So that's, hotly debated with state budgets every year. And there are 5 states in the country that have reached Medicaid to Medicare parity. So they reimburse at the same level for a patient that is on Medicare, like an adult 65 and older, versus a patient that's on Medicaid. All of our children, all of our pregnant women, and low-income adults. And so there are some states that have prioritized that. That's a very interesting point that you brought up. Is that going to drive where pediatricians set up shop? So I haven't seen that yet, but I don't see that far from what could start happening. That actually in those states that they have the ability to compensate pediatric doctors. And by the way, this is not just pediatric doctors like your general pediatrician and your pediatric trained specialist like your pediatric gastrointestinal doctor, but it's also a pediatric surgeon or a pediatric anesthesiologist. So possibly those states will become places that those that have trained in this specialty will go to, because maybe they're able to say, in this state, we pay doctors the same level, no matter if you're treating children or grownups. And I would love to say that, can New York be on that path? And that's something that we're really going to be working on over the next year or couple of years.
New-York-Presbyterian, besides just being the number one hospital in New York State, and I'm going to get this might be an old statistic that I remembered from being involved with the hospital years ago, but I think you're the second largest employer after the state itself.
I don't know that stat, but I would believe it.
Yeah, I think you are. You're definitely in the top 5. If you're not 2 now, you used to be, or in and around there. And if you think about that, that really has some real lobbying, force behind it. So that would be terrific, because in New York City, it's also, and I was just at a meeting this morning at Sloan Kettering talking about this board I'm on there. We're working to help fund to support research fellows that are coming in, and their salaries are not enough, to support living here in New York City. And some of them have children and all of those kinds of things. So if you're not paying pediatric doctors enough, they're not going to be wanting to come to this city or other cities or places where the cost of living is high.
That's exactly right. And that's exactly what we're facing.
Yeah.
I find it's very challenging to recruit pediatricians and pediatric specialists to New York City. And it's because the salaries that we are able to offer based on the revenue that we generate, based on what our patients' insurance and Medicaid being the largest one, pay us. And so we are facing, and parents in the city should know this, a dearth of pediatric specialists for sure. Like the amount of time you have to wait for a pediatric endocrinologist right now in the city is very high. And it's because we cannot even recruit them here. We cannot pay them enough to get over the cost of living.
Yeah.
But I see that it's going to happen at the general pediatrician level as well. And I think when people think about Medicaid and funding Medicaid, I think often people think about adults and adults who aren't working, but we have to think about it as our children's health care.
Yeah.
Because it is the largest healthcare insurance for children. And so as New Yorkers, we should be thinking about that. If we want our children to have great health care and to have access when they have a problem or even prevent future diseases, we need to work on this gap in payment to pediatric doctors via Medicaid versus Medicare.
So for people that are listening and are interested in this and concerned by what you're describing, I know I am, as I'm sitting across from you, to find out what's happening in their state, see what the reimbursement levels are as it correlates with what the Medicare reimbursement levels are. Is there parity there? And then it really would be sort of involve lobbying your state government,
yes.
right? Now, where are groups like the American Academy of Pediatrics on this? Are they involved in this? And isn't this sort of what they should be doing? I mean, if they're not doing it, they should be doing this?
Absolutely. There are a lot of issues that the American Academy of Pediatrics takes on, of course, including things like, the things that do make the news cycle, transgender care,
right,
getting over vaccine hesitancy. But this is what they're doing, like you said, not in the headlines, is working towards better reimbursement for pediatricians.
They are working.
Absolutely.
Yeah.
And also working on things like how we fund graduate medical education is different in children's hospitals, but that is not guaranteed. So there's, many facets of how the federal and state funding needs to come together. But yes, I think as parents, you should know. And start with asking your pediatrician. I know you already ask your pediatrician a lot. You're probably in there with a list of questions. But what is their take on how the compensation that they have available to them compared to adult doctors? They may tell you something that's specific to your state. And then also to get involved. And this is what pediatricians we need now at this point. We're coming together as many national groups, but what we need is parents to say, it's not okay to pay our children's doctors lower than our own doctors. We need parents behind us because I think as pediatricians, we have never wanted to disrupt the room, right? We want to do the right thing and make children healthy, but we're finding that we have to start raising the alarm on this. But we need the parents behind us, the parents that we stand by when you need us. We need the parents now.
See, I think to me, this is just, if parents knew about it, which is, again, why I'm so happy we're talking about this and that you're bringing this to my and, listeners' attention, is because I do think people will want to ask their elected official, their local state senator or assembly person, A, do you know about this? And B, if you do, what's your position on it? And what are you doing to try to address it? Because I think maybe there's a stigma attached with Medicaid. For some, it becomes political, right? It's a quote government program, but actually, in this particular case, it's a government program that's providing a vital service to our children. We want to be investing, I think, as a society in prevention as opposed to intervention, which is so much more costly down the line, whether it's childhood obesity, what that can lead to, or someone not being vaccinated and the larger public health effects from that. Now, what about the National Academies of Sciences, Engineering, and Medicine? What are they doing? Are they engaged at all at a federal level?
So we just had a study come out late last year that looked at this issue. Why are fewer people going into the field of pediatrics, and especially the pediatric subspecialties? Again, those doctors that you hope you never have to see.
Right.
It's like me. I'm a pediatric infectious disease doctor. And when people say, could you be my doctor? I always say, you don't want to have to see me. But I'd love to talk to you about, infections or vaccines. And actually my specialty is the lowest of the low in compensation. So I went into a field, I don't think I had any idea what the compensation was out there. I went into it because
you were passionate about it. Yeah.
Right. I liked the idea of stopping infections before they even happen through vaccination. And I thought, who do we vaccinate? We vaccinate children. So I'm going to be a pediatric doctor. That was my drive into medicine. And so we want to go back there. But our friends and colleagues at the National Academy of Sciences did look at this over an 18-month study and tried to uncover what is at the root of this. And it really, again, they saw it too, came down to economics. And what they said really is, states have had it this way for many years. They haven't fixed the problem. And so maybe it needs to be a federal program to fix the gaps between Medicaid and Medicare. And, that may need to be pursued as well at the same time as pursuing the state level advocacy. I know myself, I will be pursuing it on both ends with, the national groups that we talked about, both looking to be one of those states that can say proudly, we have Medicaid to Medicare parity. We do not pay doctors less for seeing certain kinds of patients than others. I want to live in a state that says that. But also, it may not be the fix at every state, and doing it 50 times is hard. And so maybe there is a federal fix that we also need to advocate for to fill the gaps.
And maybe if there are, political concerns about what's being, I think everybody can get behind having some sort of coverage and proper compensation for pediatric doctors and coverage for children who need it. That's just should be a baseline, right?
We all lose when children do not have adequate access to health care and health insurance. And even, the recent times with so many changes to Medicaid as the COVID pandemic's fixes kind of come off, families are seeing their coverage come and go. That is not good for children. And we all lose with that. Not only that our child may not have a disease picked up that should have been picked up, or may not have access to the treatments that they need for their diseases, but then that means that later on, this child is going to have more severe chronic complications. Think about mental health. If we could adequately address mental health and do the preventative things starting in childhood, how many fewer mental health problems would we have in our adult population?
Yeah.
And so that's just an easy example that we can all
mental health,
get behind.
Nutrition, or any kind of a chronic disease, having it diagnosed early and properly. Should we shift gears to a brighter topic?
Let's do that.
Tell me, what else is a hot topic that's exciting and positive that is not in the headlines that you're talking about or that's on your mind?
Yes. Well, there are so many exciting things in pediatric medicine, and of course, that's why I love talking about it. So I'll go any direction with this conversation. But one thing that when people ask me, what are you most excited about in the field? To me, it's the rapid change and rapid adoption that we're seeing of the potential of gene therapy.
Okay.
And genetic medicine. So in the last year, there have been 2 diseases for which we've seen gene therapies become FDA approved that were chronic conditions that required lifetime of hospitalization, treatments, infusions that we can now cure with gene therapy. And it's sickle cell disease and thalassemia. So 2 conditions that are genetic conditions that lead to an anemia, a blood disorder. They're a bit different. Thalassemia leads to an anemia that becomes dependent on transfusions, blood cell transfusions.
Okay.
And sickle cell leads to abnormally shaped blood cells that then clog up your blood vessels that can create pain crises, can create lung problems. And so frequent hospitalizations is common in those kids. And now the clinical trials were done, the safety was assessed, and those 2 gene therapies were approved. And
how recently is that?
In the last year.
Wow. Maybe I'm not reading the right. I feel like that should be a huge thing that people are talking about. And maybe I'm sure they obviously are in the pediatric medical community.
We certainly are, but I can tell you maybe why you aren't hearing about it as much is at this point in time, the cost of the gene therapy is so high that not many places are using it yet. And I say yet because I think we will figure this out, but it's going to take time, and it's going to take people thinking creatively again about how we fund healthcare. Keep coming back to that.
Yeah.
So right now, each of these treatments are $1 million or maybe more.
Each one?
Each one for one treatment to cure a disease. So if you think about the economics of it, it's if you add up the lifetime of having a disease, of multiple hospitalizations, of constant blood transfusions, what the companies did that created these amazing therapies that, again, erase the possibility of a disease, they said, well, you're saving that much money, and so that's the value of this cure.
I was going to ask, who's setting this number? And tell, just to back it up a second, what is the actual, when you say gene therapy, what does that actually mean? Are you taking someone's blood out, altering the genes and injecting it, and then it's almost like a bone marrow type procedure?
Yeah, so great question, because it's sometimes different. That's exactly, as you said, is one way and the most common right now.
By the way, that was a guess.
Well, you were right on. Much like you take bone marrow or you can take blood cells from a patient, then, generally we're seeing bone marrow transplants is for things like leukemia or some problem where you don't want your own cells back because they were the problem. This is, you can actually change a patient's own blood cells through this very targeted, CRISPR-based gene therapy that changes just that gene or even just that part of a gene that is making your blood cells the wrong shape or is making it so you don't make enough blood cells, and then give you back your own cells that are fixed in just that specific gene.
How many, what sort of sample size or do you need to actually alter the genes of all the rest of the cells that are in your body?
Yeah, so it does take conditioning of the patient. So this type of gene therapy, it takes, getting rid of most of the cells that are not corrected. But then, luckily our...
How do you tell that? How do you...
Well, you treat the patient to get rid of all the circulating cells.
So is the blood kind of coming in and it's almost like a dialysis type of a...
Well, more often involves some kind of chemotherapy or radiation that gets rid of all the circulating cells that have the wrong gene or the mutated gene.
Okay.
And then you put back hematopoietic cells that have the ability to engraft in your bone marrow and then be the cells that create the new set of immune cells and blood cells.
That's incredible.
So it's pretty amazing, and it's safer, has fewer complications than getting someone else's bone marrow because you don't have the possibility of a mismatch, a rejection event, right? Because it's your own cells coming back. So it's actually safer than a typical bone marrow transplant that we think about for leukemia. So that's one type of gene therapy. There's other types of gene therapies where the vector, that we call it, which can be part of a virus, it might be part of a lipid nanoparticle that will go to a specific organ, and because it wants to change a gene in a specific area of your body. So far, most of the gene therapies are based on circulating cells because they're a little easier to get to. But things like neurogene therapy, that's on the table now, and there is some deliveries that are delivering it directly to the spinal fluid, for example. So these are the things we're going to start to see more and more delivery systems, more accuracy, more diseases, especially that are monogenic, meaning you can tie it to a single gene. Having these gene therapies come online, get approved, and then we have the possibility of curing a disease that was a lifelong disease in early life. And that's where I see pediatric medicine changing.
But I'm disturbed by what you were saying about the cost of it, because what's going to happen is you're going to have a huge disparity between, it's sort of like people that don't get insurance coverage for any of the semaglutide shots, right? You'll see now there's people that if you don't have the insurance and you can't pay to, or insurance won't cover it to get it outside of insurance, then you're not getting access to that medicine. I think it'd be prohibitively expensive for everybody.
Almost everyone.
Yeah.
Yes.
I guess, is it covered by anybody's insurance?
Well, that's kind of where things are.
Okay.
So this is a great negotiation that's basically going on for miraculous cures. And right now it's a process to figure out how are we going to fund that in a way where the companies that spent billions really creating these gene therapies do get to recoup their costs, but then also the insurance companies that are paying for it are making sure that they can recoup their costs too. And then what's on the table right now is if a hospital were to do the gene therapy, they would essentially eat a lot of that cost. And so that's untenable for our hospitals. So right now we're seeing some just few centers that maybe they have enough of philanthropic base that they can, do a few of these. But that is really where it is. So we have such great potential. It's coming down to dollars and cents.
Yeah.
But I think, the view is we're not going to not do this, right? We're not going to sit here with this technology that, great scientists, great discoveries led us to be able to cure diseases. It's going to get done. But yeah, the people at the negotiating table need to figure out how we can not wait, because, we have children that are hospitalized chronically with complications of these diseases now. And we need to work faster. I would say to those negotiators, let's work faster. There's children who are being hospitalized now with diseases that we can cure.
And how does that relate, or does it relate at all, to genetic testing? And is that another thing that's kind of a more common practice or percolating in pediatrics?
Yes, so lots changing there. And that's, again, where I see some of the biggest change in how we're going to diagnose and really treat disease before it even starts is through genomic medicine. So right now, there haven't been a lot of reasons why you might do full genetic testing on a child. One sort of early adoption we had of gene testing is our newborn screen. So now when you have a baby, you get that heel prick and a few spots of blood go on a piece of paper. That's then generally sent to a state Department of Health lab, and they do testing for common genetic diseases. But they do maybe 50 different separate tests for these different diseases that are known that if you could diagnose a baby with that genetic disease in the first few days of life, then you are going to change what you're doing for that child. Maybe they need to have different nutrition in early life. Maybe they need to immediately get screened for their hearing or other developmental needs. So that's going on now, but it's very inefficient because we're doing 50 different tests for 50 different genes, when really the cost of sequencing an entire genome is becoming almost similar to those 50 different tests we're doing on single genes. So that's changing the economics of how we do diagnostics in children. And so one area that is a study that's going on at NewYork-Presbyterian is a study called the Guardian Study, led by doctors at Columbia, really initiated this, is that idea. Well, if we're testing for 50 or 70 different things on a newborn screen now, would we just move it to genetic newborn testing and sequence all the genes and see how many diagnoses we can pick up versus the standard screening?
Columbia, New York-Presbyterian Columbia campus doing that kind of in-house?
As a research study now, as a research study. And they're looking at how many different actionable diseases did we pick up by just going ahead and looking at all the genes rather than doing this one-off piecemeal gene diagnostics.
So would that be genes like the
BRCA1 and 2?
Yes, for breast cancer. I mean, it's not just genes that would be diseases that could develop in your childhood, but they could be other genes. I know there are some genes that are predictors of Alzheimer's disease. Yep. It's everything.
So, Leslie, this is why you run this podcast, because you just asked the most important question, right? What about
do you want to know? I mean,
exactly. What do you want to know from that? And yeah, so that's where you start getting into the ethics of it. So right now, the way that this is a research study, again, is set up is to only look at the genes that are actionable during childhood, that would change your management, either additional screening that your child needs or treatment that they could use right now to avoid some complication. And so those are the only ones that are being reported through this research study right now.
But can I ask you one question? Yeah. I didn't mean to interrupt you in here, but so can you give me an example of ones that are part of this study, genetic testing, it's part of the study, but are not part of the standard states screening?
Yeah, so one maybe example I can give you from the study, and again, I'm just an observer of the study, but I'm so fascinated by how it's going to change what we're doing. There's a standard test that we do on the newborn screen now for severe combined immunodeficiency disorder, or the bubble boy kind of scenario, where a child is basically born without an immune system. And often those kids look totally normal at birth. They have maternal antibodies at birth, so they actually avoid most severe infections for the first few months. But then they start getting really common and very critical infections, and then finally they get a blood test and say, oh, you don't have an immune system that's able to protect you from these. So there's a newborn screening test that pediatrician scientists helped develop many years ago to not let a child go to that, 4, 5, 6 months before they're recognized that they have this disorder, because then they've already caught some very chronic infections that are hard to get rid of. But if we can diagnose them early, then they get a bone marrow transplant and they can live a healthy life with preventing infections. So one example of this study is that the test that we were doing is that's standard is not a genetic test. It's actually an immunologic test. But on the genetic test, there are more known genes that cause this severe combined immunodeficiency disorder. So by testing all of the genes, you won't miss a case of that. Whereas the immunologic test we were doing has the possibility of missing a case. So it actually is adding to the sensitivity of making sure that we don't miss a single case of a child that could have been helped and cured of their immune deficiency, but only if you catch them in the first few months of life before they have symptoms. So that's an example of just improving care and preventing that chronic disease.
And do you see, I'm not going to hold you to a number that you would, it's in a trial right now, so it's probably hard to tell, but is this genetic testing sort of going to be prohibitively expensive like gene therapy, or will it be sort of standard practice like the current state testing is?
Yeah, so I see it's moving in the direction of being comparable to the newborn screening test that we're doing now. So it's not near as prohibitively expensive as our gene therapies currently are. But yes, that is what states will face eventually when they say, do we want to do the standard screening or do we want to do a more broad genetic screening, is going to come down to cost and then cost-benefit analysis. But that's why we need to do the research. We need to see, okay, how many dollars did we save by not having that child miss a diagnosis and get very sick from it and be hospitalized and have infections that were incurable? How much money did we save because we found a gene that said this child needs to have services to help with developmental achievements and needs to have speech therapy and occupational therapy in order to get them to a more functional state in that time when your brain is developing. How much did we save in healthcare costs because we did a more sensitive screen? That it may cost more, but when you look at it, how much did it save? Then that's where you make the assessment of going ahead with a new screening test like that.
And I could even see, I remember, and I still pay the storage fee for cord blood storage, which is a private company that does that. I could see this becoming a private, the private sector kind of.
Picks up on?
Yeah.
Yeah, I think you're very astute, again, asking the right question, so it could go that way. Like you could get the standard screen, or if you want to, privately pay for a full genomic screen for your child, would that be potentially offered, even outside of healthcare recommendations and coverage by insurance? Possibly. I think, we're
Is
not
that available now? No.
It's not. And, things like 23andMe, of course, are available. Those are hard for physicians and healthcare leaders to recommend because it's not necessarily giving you accurate information. Does
23andMe also give you kind of health? Does it flag genes for you that are beyond just your ancestry?
So not that I know of, but the reason is that the expertise is not there, right? And actually this is a place where AI is going to come in and actually, again, revolutionize how we look at things, because your test is only as good as the interpretation. And so right now we get a lot of interpretations that still say gene of unknown significance or mutation of unknown significance. Well, if it's all unknown significance, it wasn't any help. But that's where, more and more genetic information going into databases that can then study, okay, what was the outcome of that? What were the symptoms or diseases that developed?
And AI is kind of collating all that.
And AI will put a brand new lens on that that we're just not able to even have now. And so I see that field is going to move quickly. And even the other piece that has really changed in pediatrics is how many genetic disorders are diagnosed when you do gene screening in sick children. So children that are admitted to the ICU for various diseases, admitted to the hospital. Most children are well, right? And that's the best thing also about children in pediatrics. But when they do have an illness that's significant, it turns out that a lot of times it has a genetic origin. And so we're finding, and studies have been repeated and repeated now, that you can have a high rate of diagnosis of a genetic-based disorder in children who are very sick, especially admitted to the ICU, especially around birth. So therefore, those children, we should be screening routinely for a genetic disorder, that are the ones that would have an actionable outcome. And so that's actually being looked at right now for funding by, again, Medicaid, our friend Medicaid, at the state level. So this is a state-by-state decision that's being made now, but actually it has so much cost benefit associated with it that it's actually being discussed, is on the table. So that's, something we may see in the coming couple years. The genetic newborn screen, I think, is going to be something you'll hear more and more about potentially.
Well, it's 6:30 at night, and Dr. Permar came down here 5:30, and I don't want to keep you too much longer. I need to have you back because I did want to talk about, another hot topic, which sort of is in the news. And when I say hot, I don't mean hot in a positive way, but mental health and the really concerning statistics around that for children and adolescents. But I think we could probably have a whole hour conversation on that. So I want to hold that for another time. I do want to, for listeners that have younger children or any children under the age of 18, one of the topics that my friends, we talk about, like, how often should you have this done or be checked for this? So it's going to be like a game show. Okay. I'm going to just ask you some, are you okay? Rapid, sort of questions here. And I'd love to get your kind of, your recommendations on each of these. So how often should kids be getting checked by their pediatrician? Let's start with 0 to 5.
Well, annual is the minimum. Of course, when you are in that 0 year, it's a lot of recommended appointments. They essentially line up with vaccine schedule as well as the preventative needs. So frequently in the first year of life, then it spaces out to maybe every 6 months. Then once you get to age 3, 4, you can roll into an annual schedule for the most part, unless there's something that your pediatrician says you need to come back more often for, or you just know that something's not right with your child. And I always say that our parents are the best partner in this. So annually for sure, but more often if you think something's amiss or if your doctor tells you need to be there.
So my children's schools have always required an annual physical, but I have a very close friend her son's school, he's at public school in New Jersey, they do not require an annual physical. They require, I guess, I don't know what the schedule is, but it's not every year. So for people whose schools don't require it, still would be a recommendation to go every year. Because getting that sort of email from the school helps me sort of be like, oh gosh, I have to, it kind of keeps you on track. But you would say, unequivocally, they should be going every year until they're 18.
At least till then.
Okay.
So yes.
Oh, right, because we all should be going. That's a public service announcement. We should all be going.
We should all be going once a year, and only just for checking in to make sure that everything is as it should be. And we also know that when your children become adolescents, you're not necessarily getting all the information. And it's your pediatrician's job to get the information. So are there risk behaviors that need to be discussed or something done about? And so it's for the conversation as much as it is for the blood pressure.
Right. And also, I think growth, right? I mean, seems to be, we could do another, this is, Sallie, we're getting all of our topics, sort of, because I have a couple of friends who's, particularly with COVID, they kind of missed some of those annual checkups where their schools didn't require it. and, their child's growth, they would have benefited from having some hormone support because they were, not growing at the same rate in terms of, height and weight. Okay, what about hearing tests and eyesight?
Yeah, so your pediatrician actually does all that's required there as well, as long as you're doing your recommended annual and plus appointments. So that generally...
So just that eye chart when you go in and that kind of, do you hear the beep at your doctor's office should be a sufficient...
Essentially.
Okay.
And if your child is telling you, I can't see, it's blurry, you can start with a pediatrician, and the pediatrician may then say, okay, now you need to go to a specialist, optometrist, ophthalmologist, or hearing specialist. But generally the tests in the pediatrician's office are good until our age and you need the reading glasses. Then I think we have to go on our own.
Please, we could talk about that offline too.
That's another
I've got my size 2 readers right now, which I think I've ruined my eyes by jumping a half a size. I should have stuck with my 1.5s. Now I can't go back. But anyway, dermatologist, how often?
Well, only if there's a issue that you need to have addressed. So pediatricians actually are all of these things. They are your frontline
this should be part of your pitch. This should be part of the lobbying.
Ophthalmologist, exactly. They are your frontline dermatologist. So only if it's something your pediatrician doesn't know how to treat, I would say, do you need to go to a dermatologist? So pediatricians can do the frontline.
So really, they shouldn't be looking for any, I don't know if melanoma is even a thing with, I have never heard of a child having it, not to say that they couldn't, but so not to do sort of a mole check or any, because that's
right. That's what I now go twice a year for those because I am repeatedly diagnosed with skin precancer issues. But so no, for children, it's only if there is some sort of family history that puts them at more risk would there be any kind of routine screening. But honestly, your pediatrician is doing that. That's why your pediatrician has your child take off their clothes, put on the gown, is because they're also doing a skin check at the same time that they're doing the annual visit.
What about, I remember I did a panel with New-York-Presbyterian and Dr. Walkup, who I don't believe is in New York anymore, but he said every child should have a pediatrician and every child should have some sort of family therapist or therapist. Is there any age, or do you think it's a smart idea, I guess, to have some sort of mental health professional kind of checkup with your child? I don't know if that's becoming more prevalent these days as we're having more conversations around mental health. It makes sense to me. I haven't done it for my children, had this kind of checkup, but I just came up with this idea again here. I hear it live. I mean, but to me, that sounds like a good idea. Just to sort of, sometimes I guess when they go into the pediatrician's office, they'll check boxes about how they're feeling, and you check one to kind of see if it matches. I don't know if that's a common practice, but it's happening. So maybe that is what that is sort of the mental health check. But would you recommend that? And if so, any particular ages or?
Yeah. So just like the last string of questions, your pediatrician is your frontline, frontline for this. But it's changing how we are delivering the mental health care, and pediatricians are becoming more involved in that. Whereas kind of the old model was, if I detect a mental health problem, I'm just going to send you to a psychiatrist, therapist, whatever, who's outside. Well, what was happening? You couldn't get in, so nobody's going, right? And so then these early mental health disorders or signs of behavioral problems are not getting treated. So pediatricians are doing it differently these days. And so this is, again, and we could have that whole other episode on how pediatricians are adapting to the mental health crisis, which is, first of all, every good pediatrician should be screening at every visit for behavioral health or mental health problems, depending on the age. And
parents should be sharing any concern, right, that they have.
Absolutely. So you are the partner of the pediatrician. We get the best information from you. And then what's new, and we're still working on how these models are going to be adopted and again funded, is to have mental health providers that are partnering with pediatricians in the office all the time. So in our pediatrics practice at New York-Presbyterian, Weill, Cornell, we have psychologists and even mental health trained social workers who are working alongside our doctors, that when our doctors go in the room and screen for those potential mental health concerns, they can come out and they're positive about 30 to 40% of the time, which is a huge number. They can come out of the room and say, could you go in and assess that child as well to their mental health, behavioral health partner? And so that then leads to a series of short visits that mental health provider can get that patient in and not have to refer and have a patient never be seen because they can't get off a waiting list. So it's immediate action, short-term interventions. If you need more than that, then you will have to be referred, but the number that are being referred is going smaller and smaller and helping solve the bottleneck problem. So pediatricians are doing that too.
What about a gynecologist?
Yeah, gynecologist, I would say, well, first, your pediatrician is doing that, at least early stages. Once someone is becoming sexually active or, has any kind of problem, any kind of menstrual problem, pain, vaginal pain, anything like that, then an adolescent gynecologist may be needed. Adolescent gynecologists are hard to find. We do have adolescent gynecology, luckily, at NewYork-Presbyterian, Weill, Cornell, available, but it's not everywhere. So you'd want to look around for who an appropriate gynecologist would be. The other option is an adolescent doctor. I think these are also an unknown gem in pediatrics. So we have pediatricians who train specifically in the health of adolescents, even going up into young adulthood. This is a great option if, your pediatrician waiting room doesn't feel like it fits your child anymore, that it's, your child has more needs than that may be going towards adult.
There are puzzles and, sort of.
Yes, there's toys and small chairs. That if that's not fitting your child, or maybe, your child is in college and therefore you just haven't transitioned to the adult doctor because, who has time for that? An adolescent doctor could be a great intervening solution where it's doctors that, again, are specialized in adolescent care, in problems of adolescence, like screening for mental health disorders, talking about substance abuse, talking about sexual health. And then all the services like adolescent gynecology would be closely linked.
Part of that?
Yeah.
Okay. And is that, what would you define as adolescent? Because my oldest is 18, and I said to my husband, should she be seeing our doctor now? Or is she considered it, I guess, until you're, paying your own rent, maybe you are. Yes. But I don't know where medically that or even, cutoff is.
Yeah. Well, we talk about it in different ways. 18 is, legally, I guess. But I think we all know that children are still developing at 18. Their frontal cortex is certainly not done developing. And they're actually on your insurance, right, up until 24.
Right.
And so that is...
is that considered adolescent medicine until 24?
We consider it that. It may have some variability, but that is definitely what our adolescent professionals are doing, where they'll start seeing a child even as young as 12. But certainly those transition years, I think it's a great place to, we're not quite ready for the adult doctor or to bring my child with me to my doctor appointment. You may not want to go there.
Right.
An adolescent physician is a great intervening option.
Dr. Permar, thank you so much. I learned so much. I mean, I have a list of things here that I've made note that I'd like to have you back. Hopefully not in the evening in the rain. Oh, maybe the evening's better for you, obviously. But I mean, there's, hopefully a glass of wine and dinner waiting for you somewhere. And that, you came all the way down here in the rain. So I really appreciate it so much. It was so great talking to you. And thank you so much.
Thank you. This was a great conversation. I will definitely do it again because we have a few, or I'll send you one of my great pediatricians who is a specialist in one of these topics.
Oh, yeah,
and
great.
You can dig in more.
Great. That would be great. I'm going to hold you to that. But I appreciate it so much. Thank you so much.
Thank you for having me.
That brings us to the end of this episode of The Interview. A huge thank you again to Dr. Sallie Permar for joining us. And as always, thank you again for listening. If you enjoy the show, please rate and review us on Apple Podcasts and follow us on Instagram at The Interview with Leslie. A new podcast is released every Wednesday. And until then, this is Leslie, and don't forget to join The Interview.